That's my little editorial. Thrilled to have you guys to the stage. There is a mess in the kitchen, and tell us all about it.
Okay, so we have an interesting setup here. We've been debating on should we each take a turn to stand at this podium or sit down, and so who knows? We're going to be all different types of positions, I think, today. But we have some slides that we've prepared. I have the pleasure of being with you all this afternoon after this postprandial dip, and I'm glad we got a little bit of movement in before we got our conversation started back up this afternoon. My name's Marianna Wetherill. I'm an associate professor from the University of Oklahoma in Tulsa, and I've had the privilege and the honor of being able to work with the Sunflower Foundation over the last few years as they've worked to explore what food as medicine could look like in Kansas across the federally qualified health centers that they've had working relationships with from an integrative care perspective. And with me today are the other essential members of the evaluation team for the Food as Medicine project, including Kristina Bridges and Susan Harvey. And so I'm just going to kick the conversation off. And since they've had a more active role in collecting a lot of the evaluation data firsthand, they'll carry a lot of the middle bulk of this conversation that we have to share for you today. So I did not come up with this title. Elizabeth did. She's so creative, and we kept it, and it is very true. There is a mess in the kitchen. So I think we've all probably, if you've been in evaluation work, that is what evaluation is, right? So what have we really learned from this first year in the pilot projects for Kansas Food as Medicine? But before we start with some of the processes and results that we've taken away from the first year of this project, I wanted to first provide an overview of the preliminary work that was done before we even approached the implementation phase of this project. So at the very beginning, Sunflower Foundation did some community inquiry, which is very true with the spirit of how Sunflower Foundation does all of its work, of first seeing and checking in with the community, is food as medicine even something that you're interested in, exploring, pursuing, et cetera. And around that time is, I think, whenever I kind of came into the mix of some of those initial discussions, since I had done some work in Tulsa with a food pharmacy initiative that we had published, which is why Elizabeth initially reached out to me. But that interest was confirmed around July 2021. And so then we kind of got to work of like, well, what's the best way to maybe go about approaching the planning and development of these types of projects? And we had some really important goals that I think that we had established for this vision. The first was to try to do our best of, I think, eliminating that sense of urgency that often happens whenever we have a philanthropic, a foundation that wants to support a type of project, and then an organization rapidly saying, "Oh yes, we want this money," and throwing something together and promising something that may not be the best design for the community. And we didn't want to put that kind of a pressure on the clinics. So what we did was kind of chunk it up into some stages where clinics could choose to opt in as the process unfolded and choose to step aside if they felt like moving forward wasn't the right choice for them. So the first thing that we did was we kind of had that level setting experience, which was just a one-day experience where we had various stakeholders, including potential clinic partners, come together. It was over Zoom because this was still during the social distancing era. But we started a full-day morning session of just talking about, well, what is food insecurity and how does it affect health? What is food as medicine? What are the models that could be used? We did an introduction to the Aspen Research Action Plan and introduced this concept of how can we include equity in the design of food as medicine at every step of the way. And then the afternoon session involved further brainstorming in smaller groups of how could we maybe take what we have at each clinic level and put together a design that might work. Clinics then had a chance to decide if they wanted to apply for a pre-implementation planning grant. And this was really a no strings attached grant. They applied to participate in planning, and there was no requirement that they actually had to deliver the program that they designed. But what this involved was a series of online workshops, kind of primarily over the lunchtime hour, where we talked through things like, what does your patient population actually need? What do your providers want? What's realistic and feasible for your type of a setting? What actually might cause a positive impact that you're trying to achieve? What kind of diseases should we start with? Things like that. And so clinics really did really thoughtful design and construction of their programs that were informed by the data that they collected during this process. So for example, each clinic conducted a series of patient interviews about, what is your perception of food as medicine? Do you want to get food from the healthcare site, or is that crossing, some kind of a boundary that you're not interested in? Also interviewing providers at the sites. Would this, strain our system more, or is this something that you want to explore? Looking at their electronic health record data. Do we even document food insecurity? What's the distribution of patients with prediabetes or diabetes or depression, depending on what kind of disease state they were focusing on. As they pulled all those pieces together, the final assignment was a logic model. So you can kind of think of this
everyone.
as a tech.
We are going to do some fishbowl conversations now, and so I'm going to do a little intro to the activity. Some of you will remember in the self-paced course, we invited participation. And we ended up choosing, I think, about 8 of you that made sense given your scope of work to participate in that. So just to give a little roll call for folks to know when they're up, I'll say this now and then call you up again in a few minutes. I just want you to be ready. We haven't actually done this on Zoom.
Oh my gosh. Well, I kind of want to be on her Zoom call. I want to know what this fishbowl activity was. Okay, so the final product that was produced was this logic model that then clinics were prepared to submit as a request for funding to Sunflower should they choose to do that. And so that's basically where we were in this process when the evaluation started. So we did not tell clinics that they had to pick prediabetes or diabetes. They came to that decision on their own. From an evaluation standpoint, that was very convenient, though, for us as evaluators of, well, at least we're kind of talking about a similar population that would have similar nutrition-related goals. Settings were controlled somewhat in terms of being federally qualified health centers. The types of foods that were supposed to be part of these interventions were fruits and vegetables, other good sources of quality fiber, maybe some discussions around, replacing sugar-sweetened beverages with things that did not contain sugar, as well as a focus area. And then our outcomes, we collectively met over an afternoon to discuss options, and then we worked towards having some standardized outcome measures across all clinics. So these included things that you would expect, like food security status, their fruit and vegetable intake, and fiber through a block dietary screener, hemoglobin A1C, but also mental health and some positive psychology constructs were important for some of our partners. So we included those, including the PHQ-9 for depression, other mental health measures, including flourishing and vitality, and then the more objective things like BMI and blood pressure. And we also developed a program completion tracking spreadsheet to try to stay on top of those process evaluation types of outcomes. So I'm going to turn it off to Kristina in after I get through this slide. But what we have really appreciated as we've worked to evaluate this project is that even though at first glance a lot of these interventions look the same, if you go a couple layers deeper, they are radically different. And so we have really big variations in patient demographics that are being served, very wide variations in the degree of comorbidities that are affecting patients with diabetes at the clinic sites, differences in observations about patient readiness and the reasons why they choose to enroll in the program, as well as a lot of intervention elements that are varied, even though for the most part, many of these interventions are produce prescriptions with some shelf-stable foods that are being provided. And then as we've talked about today, settings are very, very different. And so as evaluators, that makes us ask, what recipes are we testing? In other words, these food as medicine interventions, what are we really evaluating?
Thanks, Marianna. So this isn't to scare anyone or the clinics who are here, who have all done great job. It's just a metaphor. So that's right. We've had variation. Of course we have had. And, because it's a real world setting and every clinic is different. And we talked a lot about, that today differences between rural and urban. And that planning period was so essential. But even with the planning period, it wasn't until they really started implementation and thought, oh, that's not going to work, or I don't want to do this, or we need this partner. So through this whole first year of implementation, things have shifted throughout. So to get a little bit deeper on some of those variations within patients, some variation in demographics. Across the board, we've seen kind of age about the same, kind of those older 45 to 70-year-old patients. But there's some differences in racial and ethnic and language across the different clinics, and definitely in health conditions. So some clinics chose prediabetes, some full-blown diabetes, and so we have average A1C from for each clinic ranging from 6.6, pretty low, to 11.4. So there's that range, and then also BMI from an average clinic BMI of 25 to 40, and then as Marianna mentioned, the level of comorbidities. Some had 0, some had 3 extra conditions. One clinic had 0% hypertension, and the highest was 33% at another clinic. So definitely different patients. And then also, as was mentioned, they all got to choose what kind of food they wanted to deliver and what kind of program they wanted to deliver. So the food did vary. We had some medically tailored meals, we had some meal kits, we had some produce boxes, and some shelf-stable items. Where they got the boxes kind of differed as well, and then how often. So weekly boxes versus monthly boxes. And then the supportive activities. Everyone is offering supportive activities. Ranging from one-on-one counseling and goal setting or nutrition-specific counseling to group classes, to cooking classes, to how to shop at the grocery store type of class, or leveraging maybe SNAP education classes online from a third-party resource. So that's all very different. And then who's delivering that? There's been staff turnover, which we know is inherent in, healthcare. So there's been a lot of that, and having to onboard a new person after, they didn't get that year of training, but now we have to kind of quickly tell them what the program is about. And then the level of buy-in and engagement between providers and staff members. I think someone was mentioning this morning, if you have that one person that's really engaged and it's like they choose to put their energy in that, program, then it's going to be great. And so here's an illustration of just a little bit differences of the food. So at first it might look, kind of similar, but if you take a closer look, maybe a little more proportion of fruit to vegetable in some places, non-starchy versus starchy vegetables. So some variation there. These are all beautiful pictures from Susan, who's going to talk after about her visits. Just kind of looking at, what a produce box would look like. There's seasonal availability, obviously, regional availability, to be able to get the different produce. And then for the shelf-stable boxes, some obviously were not suitable to, this sort of dietary requirement at first glance when you got what was available, then clinics realized, wait, we don't want certain items, but others, and then there was sometimes a lack of variation from month to month with what people got in boxes. Okay, and so here's a little picture of what might come in these shelf-stable boxes. And then we saw a lot about, the different virality scales and things. So this is kind of another view of this, but this shows where all of our clinics are. And you can see on this virality scale that we have, a couple that are in the blue, and then we have some that are in different variations of rural and all the way to frontier. So definitely variation. Okay, which leads us to no surprise, our preliminary results, and we're just giving you the briefest of overview with this really messy slide, which is to really take home the point that it's kind of a mess when you start to look at it. As we go on, we will be able to kind of dig into individual patient characteristics and, clinic characteristics to kind of see maybe who it worked for and who didn't work for. But when you just kind of look at it, at a glance, so of course we looked at food security. And so we're showing all of our clinics here, A through F. For F, we didn't add it because we really didn't have enough data at that point for that clinic. But you can see the 5 clinics at the top, and then the very bottom row is aggregate data. So you can see that, there's variation, but overall, food security did seem to improve, even though there's some variation within clinics. Fruit and vegetable intake, that's uniform. We know they're eating the food, so that's great. And then mental health, there's really variation within there. And we showed our aggregate data that so far the depression scale, we use the PHQ-9 scale, and then the vitality, those are like how energetic do you feel? Do you feel worn out and tired and flourishing? Do you feel like your life has purpose and kind of these quality of life? Really had mixed results. And then in our A1C, that is overall improved. We did have one clinic that alone isn't showing an improvement at this point. And then blood pressure overall kind of improved, but with some variation, and really no change in body mass index at this point. Really, well, for one clinic perhaps. So we're excited to go into the second year. Some clinics are continuing on to see kind of longer term, maybe as some of the program dynamics have settled to what actually really works, and then we'll be able to dig into looking at what characteristics are kind of tying into positive outcomes. All right, so I'm going to shift it over to Susan to talk about qualitative evaluation.
All right, so I've got one slide, but I could talk all day about this slide, believe me. So you saw that jumble of numbers up there that Kristina just showed you, and so it was a mess. And so part of that qualitative data that we have collected over this last year kind of digs in deeper and tells us the story behind why we're experiencing this mess. So I threw up there because, this is Aspen Institute that, one of their important recommendations, I think it was number 8. So to me, that's pretty high up on the list that whenever possible, we should collect that qualitative data. There we go. See, got it. I've memorized that. So whenever possible, that qualitative data should be collected to be able to explain or to complement that quantitative data. I think what we sometimes forget when we look at clinical data or some of that survey data, that there's human elements behind that data. And I think that's really easy for us to forget and to get maybe down on, we're not seeing what we should be seeing. Why aren't there more significant values? Why sometimes are there even trends in the opposite direction of where there should be? And so that human element, it's not just the patients that we've got to understand what's going on, but we've got to understand what's going on behind the scenes too. So I look at that qualitative data perspective of that human element. Now we're digging in, I call it the boots on the ground, because we're really collecting data then from the clinic staff. What's going on there? I learned so much from the clinics just from going in and our cohort 1, look at what they did. They did an amazing job. And then the wheels kind of fell off the bus with 2 and 3. But then when you learn, there was a change in staff. There was a change, and we did so well with this first cohort because we picked these motivated individuals. And then as we moved on, we decided to maybe pick those individuals that were more in need, but yet they weren't at that phase for change. They weren't at that stage of readiness yet. And we had a change in turnover of staff, and we lost our dietitian, and we're training new people, and it's wintertime and the food's just not as good at this point. So there's all of these other things that we've got to be able to pick apart and look at what's the complexity of it. Those community partners are also really vital too. I've gotten to speak with chefs, food procurement specialists, grocery stores, Hoxie's one of my favorites. They're all my favorite. You're all my favorite. But Hoxie's near and dear to my heart because I'm from a small town where there are more cows than people. And cow tipping was literally a thing because we didn't have anything else to do. But going into Hoxie, and I went into their little grocery store because I knew that's where they were doing the voucher systems with. Great way to bring in and pull into that local economy, tap into it. I walk in, I walk to my right, and it's 4 aisles because it's a small grocery store. I walk in there and I look to my right, there's the produce section, very small produce section. I go to take pictures and then I turn around and I'm like, whoa, there's a whole wall of soda and mixers. And, so we know it's really hard to get fresh produce, quality produce in some of those areas too. So that has an impact as well. So doing those direct observations and work with the community partners as well. Same thing goes with the food bank staff. Craig, I know, shout out to you, you're in the building. He helped me he took the time to show me around the food bank, around Kansas Food Bank. If you were to look, I wish you were speaking because I wish you could show the map of the area that you reach. It's expansive, it's huge, and it's really commendable what they're doing. On top of that, we can traditionally consider a food bank as a silo. They're doing great work, but now they're dipping their toes into these waters of working with clinics and other communities to be able to pull off these food as medicine programs. And then the participants, we've got to hear from the participants as well. What do they like about it? What's challenging to them? Looking at their direct experiences and their challenges and their successes and learning from them and modifying from that. So I always say, whenever we look at evaluation, you read a grant proposal and you're like, oh gosh, the process and the outcome, evaluations are always so important. As part of that process evaluation, of course it's important to measure things like dose and fidelity and reach. But sometimes what we forget about is that context in which the evaluation or the program is taking place. And so asking those important questions, because it is a mess in the kitchen and we've got to be able to understand when the 3 of us were meeting to go over the data, we were looking at it, but it was helpful was understanding what was going behind the scenes. So I know Corby asked earlier, how do you develop that trust? Well, it's just like Carmen said, it's driving the 6 hours out to Hoxie, sitting down with people, making small talk as well. I really like to get to know each other. Food, buying lunches and cookies and things like that is always helpful. That's a way in as well. But getting to know people and really telling them, I'm not here to evaluate you. We are here to learn from you so that we can make this process better. That's my qualitative slide. I could spend longer, but I won't.
Okay, so I'm going to wrap up this conversation with just some, just basic reflections and some questions that we kind of came up with, and then we can open it up for some discussion. I do want to say that I think I stole this slide from Chris Long, who had the same thing. I don't know if you stole it from somebody else, but so we're at this point in our evaluation are not able to conclude if an apple a day does anything, but we are, have, I think, more questions and that we want to explore further and figure out, really what are all of the positive impacts that these types of programs might be having on people's lives. So I am a registered dietitian, and of course I had to throw some nutrition in here, but I won't go too deep. But I just wanted to I think, remind all of us that, nutrition can impact health in many different ways. And we oftentimes think about, nutrition deficiency diseases, where I don't have a particular mineral or vitamin, and if I do not have that mineral and vitamin, this particular disease occurs. Some examples are listed up here. Probably a very common one that you can think of is like iron deficiency anemia. You don't eat enough iron. That anemia in the majority of the people with low nutrient intakes, that is going to be the guaranteed outcome that you get. We talk about WIC as being the gold standard food as medicine program that is well tested. It has, very reliable results in affecting risk for iron deficiency anemia, right? So those foods are high iron foods, fortified foods that were originally designed to fill gaps in micronutrient intakes for diseases that develop very rapidly whenever we have a deficiency. For these food as medicine projects that we are working on now, many of us, we're not picking these things, right? We're picking something called a long latency deficiency disease, which in many cases is a disease of excess, eating too much of, processed foods and not enough micronutrients that are not guaranteed to be developing in everyone that has that exposure at high rates and exposure. And so some examples of those are things that we've been talking about today, right? Diabetes, hypertension, cognitive decline. All of these have well-established associations with dietary patterns, not often specific nutrients though, and they oftentimes are bundled up in all of these other factors such as genetics, early life course exposures, environment, things like that, that from an evaluation perspective are really hard to unpick and unpack apart. And also from a design perspective, right? It's not like I can find a list of foods that will address one nutrient deficiency and fix these things. It's a different nutrition disease relationship. And not for all, but I will argue that for a lot of these food as medicine interventions, they're picking these long latency nutrition diseases, but then they're putting these expectations on them as if they were short-term index deficiency diseases. So they're expecting, a really rapid change in 3 to 6 months for something that really is a lifelong change that's going to need to be taking place. If you're in healthcare, if you're in research in healthcare, you have seen figures like this talking about, the pathway that, we traditionally take for healthcare intervention development, where we start with these efficacy trials, thinking about whether an intervention is going to create this impact under really ideal circumstances, and then moving into these effectiveness studies where we're looking at real-world circumstances for a specific intervention, and then this implementation science of how do we disseminate this and how can we adapt it, et cetera. But for food as medicine for diabetes, for the project that we're working on, we're not really working in an ideal setting. We do have some elements, of providers who are interested and engaged in supportive settings, but our patient characteristics are really all over the place in terms of what their profiles do look like. The provider characteristics are different. How long they've been living with diabetes is different. And really, it would be nice if we had a more explicit treatment treatment that we're using. But as you could see from the pictures, that at first glance it looks similar, but if you actually looked at it, it is radically different, both the foods as well as the complementary approaches. So we're really challenged at even being able to answer any of these questions because we've skipped some steps and kind of mucked things up, I guess, and jumping to implementation so fast, I think. The traditional approach, that for drug approval in the U.S., is these phase 1, phase 2, phase 3, phase 4 trials. And I think whenever we use this term food as medicine, for our stakeholders, that automatically put drugs, right, in their brains. And they expect us to be able to make these comparisons of how food lines up with drug data in this way, right? But food may be medicine, but it's not a single substance drug. And I don't think we can really, work in this kind of a model if we're going to be doing a robust job at evaluating and communicating the true value of these programs. So I'm so glad that Adrienne introduced the meaning of food earlier today. She always explains it so much better than I do. But I want to remind us that food is not a drug, and that whenever we're communicating to our stakeholders, we need to also make sure we're having that communication to them. It probably should be a greater than sign. Food is greater than drugs in many aspects. Adrienne talked about meaning of food in life, of yes, food can be used instrumentally for us to feel like we're feeding our health, but it can also be an outlet for creativity. It also is a mechanism for social cohesion and discussion and dialogue. And all of these we know from a public health perspective can have positive impacts on health. So we need to be able to look at food as, yes, being able to physically improve our health, but also how can food as medicine help people achieve health through some of these other mechanisms. And so our evaluations really need to be able to hold all of that. Julia, earlier today, I wrote it down. She said, our food system has effectively isolated people from their food, or something along those lines. And, it kind of made me think about social isolation and what we know about social isolation. It's like the equivalent of smoking a pack of cigarettes a day. So what's the impact of food isolation, of not having all of these dimensions in their full potential through food, and how can food as medicine help with the expression of all of those things, which aligns really well with food, thinking about food more broadly as food equaling health. And whenever we do have our evaluation plans that we're developing for these kinds of programs, are we able to examine, all of these factors that we know matter for health? So in conclusion, we kind of brainstormed some additional considerations for future evaluations. We've really, talked a lot internally as a group about, what does matter most? Is it the food? Is it the complementary activities, such as the one-on-one coaching? Does it have to be a lot of food? Can it just be smaller amounts of food tailored with, more intensive coaching? Does the stage of change really matter? And how can we tailor the programs to the stage of change that people are in? And maybe what can we glean from, tobacco cessation literature, right? For someone in pre-contemplation stage, we wouldn't be giving them nicotine replacement therapy, right? They kind of need to be moved up. There's different approaches that you might use. So, what can we maybe pull from that literature to help with this? Something that came up a lot with this qualitative component that Susan identified, and that was discussion of how does food as medicine affect provider satisfaction? So we've talked a lot about asking these providers to do more, and they're already burned out. But once they start seeing that food can actually help them be a better clinician, and their patients are coming back healthier and thanking them for it, how does that help with their satisfaction and their how they're feeling as a functioning member of the team? Also, reminding ourselves that food is not a single agent drug. So, how can we think more holistically in the way we evaluate our programs, and just check in with ourselves of we can't have these reductionistic models that this amount of apples will translate to this amount of change in A1C, even though sometimes some of our funders might be wanting that, or other stakeholders. However, it can be kind of hard for us whenever we're thinking about best practices in design of these programs, whenever we really don't have a lot of efficacy trials for medically tailored groceries and for produce prescriptions. You can, search the literature and you'll find all kinds of results on whether or not produce in this quantity impacts A1C in that quantity. I mean, there's so many differences in baseline dietary intake or the progression of disease that's all going to play a role in that. And if we don't know about those relationships, it can be really hard to design programs that we think are going to be impactful. And then this last bullet I would like everyone to solve today is how can we feasibly execute these community-engaged, action-oriented food as medicine programs that are responsive to what patients and providers want, but that still need to meet these payee expectations of proof within these traditional paradigms where we're often competing, well, this is what this drug does. Can you show me that this is superior or saves more money? And so we don't have answers to that, but definitely has been something to think about in our discussion. So I don't know how we are on time, if you have time for questions, thoughts.
We're actually right on time, which means we're going to destroy that moment in time because my brain is on fire, and I imagine everyone else's is as well. So I think it warrants going over schedule to have some conversation. And I'm not Richard. I don't want to facilitate. So I just want you guys to grab the mic and fire questions or ask questions, and I can run the mic around. So who wants to go first? You got a tabletop mic? Go for it.
Yeah. Hi. So at our organization, we've been talking a lot about studying, specifically focusing on mental health, mental wellness, and even less scientifically, like happiness. And so that being the category that had the most variation in your study, do you have any guesses as to why that might be to consider for if we were to step into that?
Do you want to comment on that? Oh, so do you want to talk about it first?
We all want to talk about it. Well, certainly, yes. These are such different situations and settings and people, and so we're going to have to dig into that, really. But as we were talking and looking at the quantitative, it was so cool to sit with Susan and she'd go, oh, well, you know what? At the this clinic, like this clinic that actually had the best mental health was one that was the most engaged.
Yeah, it's that if the problem that if you can solve it, engagement. And so there's a particular clinic that had cooking classes, and somehow I don't know how they did it, but they got the people there, the butts were in the seats, and it was a lot of engagement with the community. They would come to these cooking classes. I talked to some of them. I went to a cooking class. I had fun. I was cooking along with them and asking questions. And I was asking them, what is it you like about this? And they said, well, we feel like we're on a cooking show, and that's a lot of fun. But they also, and even when I was in focus groups with participants, they all said, look, we all share something in common. And, that brings us together, and we feel like we can have conversations surrounding this together. Now, these are participants that all said, you had the group, the cooking class that said, we wouldn't miss this, we wouldn't miss it. And they were very successful I think they had 3 or 4 cohorts, I can't remember. And I remember asking, what's the attendance like? And they're like, it's really high, over 70%, I think, across the cohorts that they did the cooking classes with. So really good percentages. But then talking with another group who said, yes, they say they want to get together, but then when we have them, when we invite them, we have like 2 show up. And that's with multiple text messages and emails and phone calls and follow-ups. So it, again, so variable. It just kind of depends. But like with some of the data that we were seeing, certainly some of those quality of life indicators were higher where we noticed that there was a lot more of the participant engagement going on. But that's not to say, across the board, the community health workers and the other personnel that were involved with the weekly or biweekly check-ins too, that made a lot of difference as well across the clinic. So that seems to be a key piece as well. But these are people that do want to talk with each other because they could learn from each other. They have a lot to learn from each other, and they are in a similar boat, just trying to be healthy.
Can I jump in? I was so disappointed that you said you had no idea what the answer to the last bullet point is. Because I was thinking you had found the magic mean, the golden mean. But I would like to challenge everybody who's worked with payers or is in a healthcare system to think, is there anything even in reach that looks like reality, that looks like a food as medicine program you've heard about, you've seen, you've even implemented that possibly could meet payee expectations for proof in the short term? That's the huge unsolved riddle, but it doesn't mean it's unsolvable, and maybe other people have seen things that would please a payer or meet these expectations, because it's what we're all working toward. And next panel, we're going to have some healthcare people, so
Yeah, I know. I'm
maybe
setting
they'll
us
want
up.
to talk about it then.
We're setting you up, yeah.
I just want to comment more than anything, but I think, so I see this question and I think about Elizabeth's question at the end of one of the previous sessions where, you know, if something happens in the middle of your community program, you know, and something drops off or something comes in and the adaptation to the community, you know, we need to allow for that when we're working in communities. And that's the beauty of community-based programs, community-based research. But we do need to also try to document that. And it sounds like you guys did a nice job documenting that with the qualitative. And again, you're using that qualitative to inform your quantitative. So you do need to analyze those together, and I'd be happy to help guide that and work with you on that. But it's really important, and we see that in our duo evaluation too, where we see, you know, produce managers leaving all the time. And so when we thought we could just go back to the store system and ask them, hey, just tell us when the store managers were hired, and we never got it. So now we're doing, in our process evaluation, having them pick that up. So I think your evaluation also has to be adaptable to the program. So I think that's most of my comments. I don't really have a question.
No, it's a good,
suggestion.
it's a.
No, and I'll just add, I think most of the like ahas that we had were not from the survey questions that we obsessed over. It was from the qualitative site visits and discussions and the 90 interviews that you had. And I think whenever we have interventions that are not well defined and everything is changing, the qualitative really isn't optional. It's probably even more important than the quantitative aspects.
Marianna, can I have your autograph for saying that?
Oh,
Awesome.
We've got Donna and then Mike, and then we've got a comment in the back. This is good. This is what we want. Now, I'll just say one thing. We're kind of we mixed it up with this particular research convening because we have researchers and we have implementers and doers. So this is the time where the doers get to see the sausage of the research. So we want to hear from you too. Okay, so Donna, Mike, and then in the back.
Okay, I have a question. At what point in time in your planning to do, whether there's food, complementary activities, or both, or however you're going to do this in the community, are your community stakeholders involved in your pre-planning? Are they involved in the middle? Or are they involved after you've planned what you're going to do and then implement the plans?
yeah. We were really intentional with that during the pre-planning in that we had an explicit homework, we called them homework activities, of where we asked clinics to go and actually interview patients and not only ask their patients what, you know, what, if they heard of food as medicine, what did they think about that, but that also, you know, how could the clinic help support them with their health goals through food and what would that look like. So that was part of the pre-planning process that was used. And then with our evaluation, you have talked to patients to get their feedback. And so I don't know if you want to give any insights about how their feedback has helped to inform
future work. Yes, definitely. I think all the clinics have learned, just a lot of the clinics sat in sometimes on the interviews and the focus groups that I did as well, because they wanted to learn just as much. They were so involved in the trenches of just carrying out the program that maybe, it's easy to lose sight of that direct, feedback from the patients. And so, simple things like at one of the sites, just we would like to have, the binder of these presentations and some of these recipes that we're getting. And, we get them at the end or during, but we would like them beforehand. Just little simple things like that they can think ahead for the next cohort of how that could be helpful. Or you could see from some of the food, just supplementing some of that food with, our chef today, the spices, so bringing in some of the spices and amping up some of those boxes so that it's not so daunting or so different for participants to try whole wheat spaghetti, getting some of that feedback from them as well as just, what worked as well. Some of the frozen meals, the patients liked them because they were really convenient, but when it came to taste and then translation, being able to sustain it and continue it, there was difficulty there. So I think we can learn a lot from the patients. I think this is a program, it's very much iterative. We learn at each step along the way, and part of it is from that qualitative analysis and getting that feedback from all of those different stakeholder groups. Do you want to comment on?
Yeah, just really a comment. I would just like to say thank you for considering the qualitative part, because I think as a boots on the ground person, I understand the importance of, boy, I'd really like to see that A1C improve. I'd really like to see that weight go down. But I'm talking to people who are participating, and they're telling me that their life is improving. And maybe it doesn't show up on a PHQ-9, but I can hear it and see it. And we saw it on a good example of that on the video that we saw yesterday. So I think that is important. And it almost kind of reminds me of the CGM story, continuous glucose monitors that came out several years ago, and I couldn't get any of my patients qualified to have one, but I'd give some to some, and they'd be like, man, I figure out what my glucose is doing, and I eat different, And so finally, some data comes and follows, and now we can get CGMs paid for easier than we could before. It's the same thing. It's almost like common sense. Let's just use some common sense here, and then maybe the data will come and support that. And I think a lot of what we're seeing from the qualitative side of things is common sense. This makes sense to people, and it makes a difference in their lives. And hopefully, at some point, the data will come along and support it.
Yeah, you make a great point. Just a couple of the stories I heard from patients, just quality of life indicators. One individual that traveled back and forth from Dodge City to Wichita and having to go to the bathroom several times, and then just from some of the education and monitoring his own glucose, was able to make those trips without the multiple bathroom stops. To him, that was life-changing, and that was a huge quality of life. Another patient who had high blood pressure, diabetes, just couldn't even fit into her shoes anymore, and just some lifestyle changes as a result of the program, was able to get into something other than flip-flops, and that was special for her. And so to hear those types of stories, that's important because it goes beyond that data. I agree, Mike.
Question, comment in the back?
Yes. This may be a simple question, but I was wondering when designing FIM programs, or at some point, is there an opportunity for payers, those organizations and community members to be at the same table? And if so, what does that look like?
Mm-hmm. I think that's a dream. Yeah, I mean, that we all want to see happen. And maybe convenings like this are the first step. I think that's great.
And you are, I did not pay her to ask that question, but that will tee us up to a panel that we'll have in about an hour with some payers doing some demonstration projects and working directly with community partners. So it is. Any more in the back, Brandon? Okay. Okay, I don't feel so bad then. What an amazing conversation. Thank you so much. To the EAT team.